and each of the sections within these topics are also topics in and of themselves. So what we'll do is we'll have kind of an interactive session. I will ask you all some questions and I will go through some concepts and test you on those concepts. Certainly there are a lot of guidelines which are ever changing in the field of hepatitis C, and not so much with hepatitis B, but there's also a few advances in hepatitis B that you can refer to. They're called the AASLD guidelines or the IDSA guidelines. If you Google them, you get them. And also you have web modules. The main web module that I found useful is actually from the University of Washington. And whenever you get a chance, you can take a look at those web modules if you're interested in this topic. So we at Walter Reed actually see patients with hepatitis B and C along with a hepatologist. So we have a gastroenterology division that also has hepatologists in them. So we kind of share these patients, which is really helpful to us. So today we'll basically, the outline of the talk is to discuss the public health importance of hepatitis B and C. We'll talk about the natural history of hepatitis B infection, the treatment. We'll talk about hepatitis B vaccination. I think regardless of what you do, there's something you should know. We'll also talk about post-exposure prophylaxis because most patients will at least come across one or more than one person who will need post-exposure prophylaxis. We'll also talk about the epidemiology of hepatitis C, specifically in the United States, evaluation of a patient with hepatitis C, and treatment of hepatitis C. The treatment of hepatitis C, every 6 months or so it changes. So it's really it's a field that's in a lot of flux and a lot of demand on that. So hepatitis B is a major public health problem. It's in overall world over about 2 billion people who have been infected with hepatitis B. About 250 to 300 million are carriers of hepatitis B. And about 25% of these carriers will have chronic complications from hepatitis B. In the United States, as of 2013, there were still 20,000 new infections approximately. So given that we have a universal immunization program in children, it's kind of baffling that we still have 20,000 new infections. And it's believed that there are about 800,000 to 1.4 million people with chronic hepatitis B in the US. So who do you screen for hepatitis B? Some of this is kind of a no-brainer. Obviously, you screen pregnant women because pregnant women, you don't want them to transmit hepatitis B. You screen people who are born in areas where there's a high prevalence of hepatitis B that is greater than high or intermediate prevalence, which is greater than 2%. And I'll show you a map of the world where there's high prevalence of hepatitis B. You screen children who are born to immigrant parents, that is, parents who come from regions where have high prevalence of hepatitis B. There's a prevalence of greater than 8%. You screen any infant who's born to a mother with hepatitis B, needle sharing contacts, household contacts, or sexual contacts with patients with hepatitis B. Men who have sex with men, HIV-infected individuals because of common routes of transmission, injection drug users, anybody who has an elevated liver enzyme, you would screen them, hemodialysis patients because they're in constant exposure with blood-borne products, and anybody who has an exposure to a body fluid, and organ donors. I highlighted in red a particular group of patients that we don't think of often when we screen hepatitis B. These are people who need immunosuppressive and cytotoxic therapy. So there's been kind of a revolution in medicine, because there's so many monoclonal antibodies these days. These monoclonal antibodies basically destroy your immune system completely. So even if you have resolved hepatitis B, it can reactivate. So people who had or going on chemotherapy, for example, for lymphoma, we use a regimen called R-CHOP, which is rituximab plus CHOP. Anybody who gets rituximab should be screened for hepatitis B. And if they have any evidence of hepatitis B, actually put on prophylaxis. Most of the patients that I've seen in the past year or two have been in this category. So this is a map of the world. The areas indicated in the dark green are those areas which have like high prevalence of hepatitis B, which is greater than 8%. The ones that are in the lighter greens, pretty much the entire Asia, Southeast Asia, China, Asia, Southeast Asia, they have a prevalence of 2% or higher. Sub-Saharan Africa and places in West Africa, they have a prevalence of 8% and higher. Sorry, everywhere else is less than 2%. So does everybody know how to read a hepatitis B serology? Because this is often where we get consulted on, just to help read the profile. So just polling the audience, what do you think would be somebody who has acute hepatitis B? What would be the profile of that patient? So the hepatitis B core antibody IgM will be positive. hepatitis B surface antigen may be positive, but the hepatitis B surface antibody is often negative. And the IgG to core is often negative. So that is somebody who falls in this category. What about somebody who's been vaccinated?
IgG.
So just the surface antibody will be positive, the core antibody will be negative, as you can see over here, and the surface antigen will be negative. So somebody who's had resolved infection is somebody who has anti-HBC, which is usually an IgG, and an anti-HBS that is positive, but the surface antigen is negative. So these are kind of something that we learned in medical school. Most of us know what it is. People who are chronically infected are those who have a positive surface antigen for 6 or more months. So they all have a positive surface antigen. Some of them may have an E antigen that is positive, and some of them may have an E antigen that is negative. But those that we have problems with are people who have just a core antibody positive. They don't have anything else that's positive. So what does that mean? So an isolated core could mean many different things. For the most part, an isolated core is somebody who's had resolved infection but just lost the surface antibody. Isolated cores can be false positive. And of course, it depends upon the setting. So if you have an HIV-infected patient, which is often the patients who receive these isolated core antibodies, they have an isolated core that's positive. It's often due to resolved infection.
What's the difference between anti-HBC and anti-HBS?
So one is an anti-HBS is the antibody to hepatitis B surface antigen, whereas anti-HBC is the antibody to hepatitis B core antigen. So the surface antigen, once you get the antibody to hepatitis B surface antigen, whether it's through immunization or infection, you're immune. But a core antibody just means immune exposed. Or somebody who's been purely vaccinated will not have a core antibody positive. So then you have false positive. So in the setting that I see this isolated core, often these patients have HIV. And these patients often have both a core and they have HIV because they have common risks of modes of transmission. We just assume that they have resolved infection. Sometimes they have low-level chronic infection. You check the DNA, because we check on them, and they have some low level of anemia also. So they have active infection, but for some reason a positive surface antibody. And if you have dissolving acute infection before you get the surface antibody, you lose the surface antigen, and sometimes you might just see the core antibody. So you're asked to recheck it in 6 months. So this is the natural history of hepatitis B infection, and I'll spend some time going through this because it's important to understand the natural history of hepatitis B for you to actually understand who and when to treat. So there are 2 primary mechanisms of transmission, either perinatally or very early in life, horizontally from the mother to the child. Or it's later in life as an adult that you acquire it either due to high-risk behavior or mucosal or body fluid exposure. So if you acquire hepatitis B perinatally, you go through what are called different phases. The first phase is what's called an immune tolerant phase. Then you have the immune clearance phase. And then you have an inactive carrier state. And then you have reactivation. That can happen. So if you acquire hepatitis B as a child, perinatally or through early transfer from the mother to the child, you usually don't resolve your infection. It's rare to resolve your infection. Whereas if you acquire it as an adult, you often resolve the infection. So you often become surface antibody positive. Only 5% of patients who acquire it as an adult will develop chronic persistent infection. If you're immunocompromised, such as if you're HIV infected and you acquire hepatitis B, then this ratio is a little bit different. It's much higher for chronic persistent infection. But for the most part, if you're an adult and you get hepatitis B, you're going to have a self-limited infection. So this is the different phases that we talk about and how we define the phases. So for the immune tolerant phase, your ALT, AST is usually normal. And normal in this case, it's important to know the nuances of this, because normal in a man is an ALT less than 30, and a woman is an ALT less than 90. At Walter Reed, the upper ends of normal are 44. So if you're 44, you have an ALT elevation. It's not normal. So whether you're a man or a woman. So just remember this, that when you're calculating ALT in patients with hepatitis B, you have to use the pattern of 30 and 19, and not what your lab provides you. So your HBV DNA is usually greater than 1 million copies. Your hepatitis B antigen is positive. But when you do a liver biopsy, you have minimal inflammation of fibrosis, which is interesting, right? You think that somebody who's so viremic would have a lot of inflammation and fibrosis, but they often do. often don't, sorry. So patients who perinatally acquire this infection usually stay in this stage till they're about 20 to 25 to about 40 years of age. And most patients who acquire it as an adult don't usually have an immune tolerant phase. Then you have what is called an immune active phase. During the immune active phase, your ALT is elevated. It's usually greater than 3 times the average of normal. Your HBV DNA is greater than 20,000 IU per ml, and your hepatitis B E antigen is positive. And you have moderate to severe inflammation or fibrosis when you do a biopsy. Then you go to the inactive state where your ALT is normal, your hepatitis B viral DNA is less than 2,000, your hepatitis B E antigen now is negative, and you have minimal inflammation but you have variable degrees of fibrosis. And at any stage you can have reactivation. So when you have reactivation, things go crazy. So you get an elevated ALT and elevated DNA, but your E antigen tends to be negative once you've converted it, and there's moderate to severe inflammation fibrosis. So we'll go through 3 questions and I'll quiz you as to what it is because it was a little bit of information to absorb. So one thing you should know is that these phases, I just make it sound like it goes from one step to the other, the other, the other. They're really not static, you're going from one phase to the other. They can progress in the reverse direction or in from the inactive phase to the active phase. Usually when this happens, it's because somebody has stopped their medication. Like, they've been on hepatitis B drug for like 11 years. The doctor decides to stop it to see what happens, and then they reactivate. When you withdraw steroids, they can have a reactivation because the steroids keep them in check. And when you do a biologic, like I referred to, like rituximab, or you give them cancer chemotherapy, you can do reactivation. And it's also important to realize that even if you resolve your infection, if you're given a potent biologic, you can have reactivation. So here's a question for you. A 32-year-old Chinese American woman whose mother was born in China. And the reason we use this example is because she comes from a place with an intermediate prevalence. Her mother was recently informed she had chronic hepatitis B, so the patient asked to be tested for hepatitis B. Her results are as follows. She has a hepatitis B core antibody that is positive, hepatitis B core antibody IgM that is negative, hepatitis B surface antibody that's negative. She has an E antigen that is positive, an E antibody that's negative, and she has an HBV DNA which is in the millions, and she has an ALT which is normal, less than 90%. So what phase of hepatitis B is she in? So chronic is right. Is it immune tolerant? Is it immune active? Is it inactive? What is it? Somebody lift up your hand because you're inactive. So she is in the immune tolerant phase of hepatitis B. She's between the ages of 20 to 40. She fits the other description of probably perinatally acquired because her mother is positive. She has chronic hepatitis B because she has a surface antigen that is positive, which I don't give you, but generally the E antigen is positive, the surface antigen is also positive. She has an IgM that is negative, so this is not an acute infection. She has a surface antibody that's negative, which means it's a chronic infection. And she has a core antibody that's positive, but the most important thing is the DNA is elevated and her ALT is normal. So we'll go over the same woman again. She has the same parameters as the top. But now we have hepatitis B core antibody that's positive, a core IgM that is negative, a surface that's negative, an E that is positive, E antibody is negative. Her hepatitis B DNA is 30,000 IU, and her ALT is 112. So who's going to take this one? What does she have? Somebody lift your hand.
Chronic.
Yeah, so she has immune active. And the reason she has immune active is because she has both an elevated DNA and an elevated ALT and an E antigen that's negative. Remember, immune tolerant, the ALT is not elevated, it's normal. So finally, same patient again. Of course, everything on the top is about the same, but now I tell you that the E antigen is negative, the HBV DNA is 1,000, and the ALT is 15. So what does she have? I'll let you read over that.
Sorry.
She has an inactive hepatitis because her E antigen is negative, her DNA is fairly low, it's less than 2,000, and she has normal ALT. Okay, so I think you need to know these 3 phases and understand these 3 phases. The way I remember it is in 1, the immune tolerant, the ALT is normal. For the active, the ALT is elevated. And for the inactive, again, the ALT is negative and the hepatitis B E antigen.
Okay.
Sorry, can you go over that summary again, what you just said?
I said the way I remember it is for immune tolerant, the ALT is normal. The E antigen is positive and the DNA is positive. For immune active, the ALT is not normal, it's abnormal. And the E antigen is positive and the DNA is high. And then for the inactive, the DNA is low, the E antigen is negative, and the ALT is normal. So if the ALT is elevated greater than 2 times the upper limit of normal, we've gone to the immune active phase.
You said, what was she, what's her diagnosis, you said?
She has inactive, chronic inactive.
Okay, thank you.
And the reason she has chronic is because she doesn't have any antibodies to the surface antigen. So she's not resolved with infection. She's still hepatitis B surface antigen.
But she's carrier.
Sorry?
It's carrier.
She's a carrier. Yeah, she's a carrier, but she doesn't have any activity. She's a chronic carrier. She probably can't transmit as well, but certainly can transmit. So what are the indications for treatment? So we spend a lot of time discussing these spaces because the indications of treatment are dependent on identifying what phase they are in. Okay? So if she has, if irrespective of what the E antigen is, it's all people with chronic hepatitis. Irrespective of what the ALT is, irrespective of what the DNA is, if they have decompensated cirrhosis, so they have ascites, they have portal hypertension, they have varices that are bleeding, you've got to treat them. If they have acute liver failure, like they're acutely infected and they have like a coagulopathy, they have ascites, portal hypertension, you would treat them. If they have compensated cirrhosis, most people would treat them if they have any DNA. So the guidelines say DNA above 2,000. I wouldn't remember that. Most people would treat if they have compensated cirrhosis. So if you have cirrhosis or acute liver failure, you would treat. So what if you don't have cirrhosis or acute liver failure? This is the majority of patients we see here. So the ALT is elevated and the EN, so these are people who have chronic hepatitis B, but they're the immune active phase. The hepatitis B E antigen is negative, but the DNA is greater than 2,000, then they should be treated. You don't actually have to remember all this. I know it's a lot of information, but I was asked to push it out, but just remember that there are firm guidelines that you have to know for treating. That, you can't just look at somebody's viral load and say, hey, your viral load is 1 million copies. Of course you can treat them because it seems like the right thing to do. It's usually not the right thing to do because the viral loads are so high that you may be able to get the viral loads down, but it doesn't really help their prognosis. And you may give them drug resistance. So it's really not the right thing to do. It's kind of the bottom line message. But we can go over a few of these things if you like. I don't mean to confuse you, but it is kind of confusing. So ALT is greater than 2 times the upper limit of normal. You look at the E antigen and you look at the DNA. And if the E antigen is negative, but the DNA is greater than 2,000, you would still treat. If the E antigen is positive, the DNA has to be greater than 20,000 for you to treat. If you have significant inflammation and fibrosis, so you do a biopsy, you find that they have significant inflammation and fibrosis, again, you have the kind of same criteria to do. So if you have immune tolerant hepatitis, the one that I told you would normally not treat, you would do so if they're pregnant, because you don't want them to transmit it to their child. Usually we start therapy second to third trimester pregnancy, when there's not that much of issues with malformation or really anything in the fetus as such. And then you would treat it, some people would treat it if their viral load is really high or if they're old or if they somehow get a biopsy and the biopsy shows inflammation.
How effective is the prophylaxis for to decrease the transmission, the transmission?
It's very good because within 4 or 5 months you'll see, like within 3 months of starting therapy, the viral load declines significantly.
Percentage-wise,
I don't know the exact percentage. Because you not only would treat the mother, but you would also give the child hepatitis B, immunoglobulin, and
when they
vaccination.
born.
Yeah, so you do all the 3 of those things. But I don't know exactly what it is. For example, for HIV is almost next to 0. If the viral load is undetectable, you can't transmit it.
But probably the studies are not really clear because babies get the immunoglobulin and then they shock and all this stuff.
Yeah, most mothers in the developing world are not getting therapy for hepatitis B. The babies are getting immunoglobulin from the shot. But in the US, if you see a pregnant woman and she's coming to you for consultation, then you will definitely start on therapy to prevent the transmission. So there are a lot of drugs against hepatitis B. The latest hit in the market is tenofovir alafenamide. But the main things, you probably all have heard of interferon, peginterferon. We barely ever use it. There are some situations where we would use it, and we go over that. Then you have 3TC, which is also known as lamivudine, which is generally not used anymore. It's only used in HIV-infected patients because they come co-formulated medications with 3TC. Entecavir is generally not used. Entecavir is used. Lamivudine is not even available in the US. Tenofovir and tenofovir alafenamide are used. So peginterferon, you generally give it to very young people who have well-controlled disease. And the reason is because there's a finite duration of therapy. But the others is years and years and years, like 5 years or more. So, and it's very difficult to tolerate peginterferon. It causes a lot of side effects, so most people don't want to really take it. Entecavir and tenofovir, they're bolded because they're the bulk of therapies done with entecavir and tenofovir. So with entecavir, in somebody who's naive, who's never received therapy, there's a very low risk of resistance. Remember, these viruses are millions of copies, so they can develop resistance. But however, if you've received previous drugs, like you've received lamivudine, then entecavir is not such a good drug. Because if you're resistant to lamivudine, you're very unlikely to be, entecavir will probably not be a good choice for you. Tenofovir is probably the backbone of therapy in the US, and it works against lamivudine-resistant isolates. There used to be a time when tenofovir was an issue because of the renal and bone toxicity. It's no longer the case because we actually have another type of formulation of tenofovir called tenofovir alafenamide, which is TAF, and it has much lower risk of kidney and bone toxicity. This is something that they can test you in your boards. It's FDA approved for treatment for both HIV and hepatitis B. So lamivudine is just good to know about it historically. And like I said, lamivudine is not available in this. So we're just going to briefly go over monitoring patients. I'm not going to walk you through the algorithm, but just to point out that at 12 weeks, you need to do, after you start somebody on therapy, you need to do some labs. You need to do an HBV DNA and a liver panel. That's about 3 months. You should see a greater than 1 log decrease. So if you're a million, like if you're 10,000, you should be down to 1,000. So if you're a million, you should be down to 100,000 or lower. So if you see that, then probably the drug is working, so it's very effective. You just continue to maintain them on therapy and keep checking a liver panel, HBV DNA, and hepatitis B antigen to see if they seroconvert. If their viral load is not less than a log and you have not received prior therapy, then there's some issue. They're probably not taking their medicines, which is the most common thing, and you counsel and reinforce adherence, but if they are taking their medicine, then you probably need to do a resistance testing and change. So if you start them on immunity, you put them on tenofovir. So if they're already on tenofovir, you might add entecavir to that. So if you are, again, it's kind of similar. So the main thing, the goals of therapy are to make sure you get your DNA under control, and you also get your seroreversion, which is you convert somebody who's hepatitis B antigen positive to negative. And you generally continue therapy for 5 years, a year after they seroconvert, and generally it takes about 5 years for all of this to happen. Most people want to stop therapy for at least 5 years. So we'll switch gears a little bit. This is probably more important than all the things I told you, because at least in the US, I think most of you will refer the patient to IV or pathology to deal with it. But for hepatitis B vaccine, you need to know it's safe in most individuals. The only contraindications if you have allergy to yeast. I'm not exactly sure how you figure that out without having allergy testing. But if you're hypersensitive to yeast, it's a contraindication for vaccination. It's not contraindicated during pregnancy. It's not contraindicated during lactation. It's a killed vaccine, so it's not contraindicated for a lot of things that live vaccines are contraindicated for, and should not be administered to a patient who's moderate or severely ill. So who do you give the hepatitis B vaccine? It's conveniently divided into 3 categories. Persons at risk for infection and sexual exposure, which is kind of similar to the patient who's screened. So sex partners, if you're a sex partner, if you're not monogamous, which in my clinic a lot of patients are not. Persons seeking evaluation for sexually transmitted infection, men or sex with men, they all should receive the vaccine if they've not received the vaccine as a child. If you're a healthcare worker, if you're in household contact with somebody with hepatitis B, if you work in a residential facility where they're developmentally disabled people, if you get end-stage renal dialysis, they won't even let you get dialysis to get your hepatitis B vaccination shown approved. It's really a bad time to give it to them because they don't really respond very well to their end-stage renal disease, but they're absolutely recommended for those patients. So if you're traveling to some area with a high or intermediate prevalence, it's recommended if you're going to stay there for long. Let's say you're going TDY to Africa, then they would recommend it if you've not had it already. Persons with chronic liver disease should get it. Persons with HIV infection should get it, and all other people, basically anybody who wants hypertension should get it. So this is kind of the indications, but in our case, it's not usually an issue because either they received childhood vaccination or they received it at the So there are different formulations of vaccine. The most commonly used ones are Recombivac's, Engerix, and Twinrix. So the Recombivac's is important to point out that it comes as a 40 microgram dose. It's the 40 microgram dose that you use in renal failure patients. Otherwise, you use the 10 and the 20 microgram dose. So the schedule is 0, 1, and 6 months. You can also do 0, 1, and 4 months, 0, 2, and 4 months, 0, 1, 2, and 12 months. If you use, sometimes we see patients in clinic who haven't, got their orders or got their orders quickly. Then you can give this really accelerated schedule, which you can give 0, 7, 21 to 28 days, and 20. So you give 3 doses within a month, and another dose at the end of the year. And like I said, people with renal failure should get a 40 microgram dose. Sometimes we try to do this even with people who are immunocompromised. So vaccine response, you order a hepatitis B surface antibody, you get a qualitative usually. If it's qualitatively positive, it means it's greater than 10 MIU. And you should really check it 1 to 2 months after you complete vaccination. So we often get patients who come to our clinic because we're consulted on, we give them 3 shots, but they don't have a response. So what do we do? So if you don't check it 1 to 2 months after they complete their series and they're negative after that, that doesn't mean that they did not respond. It just means that you didn't check them right then. So after a single dose, you'd expect about 50% to be responders. After 2 doses, the number goes up to 70 to 75%. And if you're otherwise young and have no other issues, 95% will respond with 2 doses of the vaccine. Poor response is older age, obesity. Obesity is a risk factor for almost any vaccine, smoking, chronic medical condition, and your immunosuppressor is low risk. So this is something that we get consulted more often than anything else. Is what you do when somebody has a needle stick injury or has had exposure to somebody with hepatitis B. So first you recommend, like they would do, is wash wounds and skin sites exposed with infectious material with soap and water. Do not using like an antiseptic like 2%, 2 to 4% chlorhexidine. There's something called Caddy wipes in most of our programs. We use a Caddy wipe, well that's not good enough. What you need to do is really wash your hands well. Should not be used, do not use bleach. Irrigate the mucous membrane with water. And before you come down to see us or before you come down, you need to report the incident so that there can be appropriate follow-up that's organized. And you should seek medical treatment. So we're going to go through several scenarios. I'm sure most of you run through this. So this is what you're going to do for these patients, right? So these are all patients that are seen at some point in the clinic with different kinds of permutations and combinations. So a 27-year-old surgical intern presents the ID clinic for a needle stick evaluation. He reports that his stuck his finger while suturing a patient. So he's suturing a patient, he stuck his finger. So just prior to starting his residence, he had his hepatitis B surface antibody check, voila, and he has a documented titer of 10 MIU. What do you want to do for this patient? No further testing is needed for either the index patient or the healthcare provider. Test the index patient for hepatitis B surface antigen. If the index patient is positive for surface antigen, administer HIBIC, which is hepatitis B immunoglobulin, to this healthcare provider, or just administer a series of hepatitis B vaccines. So you have to tell me why you picked it also. Any takers? I think this side has the answer, so some taker from this side. It's an easy answer, I promise you. No takers?
No further testing.
That's correct. So you don't need any further testing. And why is that? So you don't need to test either the provider.
Gets a documented level for it.
Yeah, so even though the person is nervous, you just need to tell them there's no need for further testing, either the index patient or the provider.
Either should be more than 0.5, that's good enough.
Sorry?
Either should be more than 0.5, that's good enough.
For us, it has to be 10 MIU. I don't know if it corresponds to 0.5 where you come from, but it's 10 MIU.
Would you test on those for other things?
Yeah, you would test them for other things. This is just primarily hepatitis C. You would check for HIV and hepatitis C. And you know, if there's a very high risk patient that you got exposed to, somebody would check that. In our clinic, RPR also, because we IHN patients often have syphilis together. So yeah, you would definitely check them for other things. You just hepatitis B. So same intern, he presents the ID clinic for a needle stick evaluation. Again, same thing. He stuck his finger with suturing a patient. He's received 2 series of the vaccine. He's received 2 series, so he's had 6 doses of the vaccine. And it's been given at the right time, so 016, 016. And he's not responded to the vaccine even though they checked the titers at the right time. The patient that he's operating on died during the surgery. Here's the most appropriate option. More than one option may apply. No further testing is needed for either the index patient or the healthcare provider. Administer another series of hepatitis B vaccine. Administer 1 dose of Kidney, or administer 2 doses of Kidney separated by a month apart.
You guys,
2 doses of Kidney. You're correct. So why not administer another series of hepatitis B vaccines? So that's a good guess, but if you don't respond after 6 doses, you're considered a non-responder, right? You'll see some of these charts and they're receiving like 12, 15, 16 doses of vaccine. What are you doing? 6 doses, good enough.
What if the gut just hadn't had, like any doses? Well, I mean, that might be the next one.
There may be another question about that. Okay, so basically in this case, I'm telling you that he's a good intern, he has everything documented. This is the military healthcare system, this is not Washington Hospital Center where you don't know his immunization status. So you have to treat them as unknown for the most part, but here you know, he's received 6 vaccines. So basically you administer 2 doses of COVID 1 month apart. So now we have the same intern, he reports that he stuck his fingers while suturing a patient. He's received a series of Hep B vaccine, but he's unaware of his vaccination status. So you don't know what his hepatitis B surface antibodies. Patient is being operated again, died during surgery. Now what do you do? No further testing is needed. Administer another series of hepatitis B vaccine. Administer 2 doses of Kidney. And the results of hepatitis B surface antibody testing of the healthcare provider will determine the treatment course. The last one is correct. Because here you don't know what his status is, so you really can't do it. If there was an option to give Hibig and then check his hepatitis B surface antibody, you could do that. Like while you're waiting for the hepatitis B surface antibody, you've already given the Hibig. But usually it's, you get your hepatitis B surface antibody results so quickly that that's not an issue. So this is just a table to summarize what we already discussed. So if the source patient is negative, you don't need to do anything. Obviously, he's negative. If the patient has a documented response or if he does not have a response. Okay? If the source patient is positive, but the healthcare provider has a documented responder, you don't need to do anything. If the healthcare provider is a non-responder, you give 2 doses of Kidney a month apart. So this is where the confusion starts. Index patient is positive or unknown. You don't know, which is often the case. You don't really know what the index patient has. It's only in the military healthcare system where you have really good documentation that you actually know what the index patient status is. Often you don't know. Then, or if the subject's response is unknown after 3 doses of vaccine, you check the vaccine response, like in the third case. If it's less than 10 MIU, you give Hibig times 1 and initiate vaccine series. If it's greater than 10 MIU, no action is needed. If it's unvaccinated or incompletely vaccinated, so you don't know whether he's vaccinated or if he's received the series as he's supposed to, you again do the same thing. You give Hibig, you start the vaccination, and you either complete the vaccination, they're completely vaccinated, or they're unvaccinated, you also initiate the vaccination series. If the index patient is unknown, and obviously this response is unknown, you check the vaccine response. If it's less than 10 MIU and he hasn't received 2 series, you give another vaccine series. If it's unvaccinated or completely vaccinated, you complete the vaccination series. So switching gears a little bit, we'll talk about hepatitis C. So in the United States, about 3.5 million people are infected. There's a birth cohort that's between 1945 and 1965, which has a very high prevalence of hepatitis C. And then 40 to 85% of persons actually infected with hepatitis C are unaware that they actually have hepatitis C. This birth cohort is important to know because if you just look for risk factors for hepatitis C in your check, like percutaneous exposure, injection, drug use, sexual transmission, mother-to-child transmission, so on and so forth, you will miss about 80% of the cases. Because most people who have hepatitis C in the US actually don't have any of these risk factors. They just happen to be born between 1945 and 1965. So what you do, everybody who's been born in the age group 1945 to 1965 should be tested once at least. And then you can test them repeatedly if they have some risk behaviors. If they don't, if they're being, let's say you're born in 1975, so you really are not the birth cohort testing, but you do it based on risk behavior. Again, the risk behavior is very similar to Hep B, HIV, Hep C, they all have kind of the same risk exposure, IgU, intranasal illicit drug use. So I put up men of sex with men because this is an emergent group who can get hepatitis C sexually. Hepatitis C, you might have heard or read when you were students that it's very difficult to transmit sexually. It is very difficult to transmit Hep C heterosexually, but homosexual contact can transmit hepatitis C. And most of the patients we see in our clinic with acute Hep C these days are MSM. So I put that down there. This is not from the CDC, but this is a group of patients that we check for hepatitis C. Risk exposure, obviously hemodialysis, tattoo tolerance, where you get tattoos where it's unregulated. This is another place where there's a lot of transmission of hepatitis C. Shocks, mucosal exposure, HCV infected mother. If you had a blood transfusion prior to 1982, so if you were born in 1980, you had an accident, you needed a blood transfusion in 1985, then yes, then you should get tested. If you received clotting factors prior to 1987, then you should get tested. If you're incarcerated, which is another group of patients who have a lot of FC, you should get tested. And finally, you have people who have chronic liver disease because we're finding out what it is that's causing their chronic liver disease, HIV, solid organ donors, and prior to initiating PrEP. So PrEP is pre-exposure prophylaxis. Prior to initiating pre-exposure prophylaxis for HIV, we check for Hep B and Hep C. And if they're Hep B non-immune, we immunize them. And if they're Hep C positive, then we treat their Hep C. So Hep C testing is not as complicated as Hep B. This is a complicated flow sheet, but basically what you do is you order HCV antibody, which is usually an ELISA test. If ELISA is positive, you get a RIBA, which is a confirmation test, and you get an HCV RNA. So you can see false positive ELISAs. We often see false positive ELISAs, and we get consulted. Usually it's a pregnant woman who's got a false positive ELISA, so we then do a RIBA and we do an RNA. If the RIBA is reactive, and the ELISA is reactive and the RNA is negative, then the patient has resolved infection. If the RIBA is negative, then the patient has a false positive HCV. So this is kind of a schema for hepatitis C. You're exposed, 20% will spontaneously resolve, 20 to 30%, depending on what literature you use. 80% will develop chronic hepatitis C. Of these 80% will be stable or very progressive, and 20% will progress to cirrhosis. Most patients are slowly progressive, but some people may have fulminant progression, require transplantation, or they may develop hepatocellular carcinoma. Usually it takes about, usually the progression is about 20 to 25 years. So I think hepatitis C is a very interesting disease. Most patients, I think I get consulted with hepatic manifestations. I don't get consulted when it's easy, like when you can easily make the diagnosis yourself. So you have to remember that when you see some patients with certain diseases, that you should think about the association with hepatitis C. Similar with hepatitis B, like for example, if you have somebody who has polyarthritis nodosa, hepatitis B should be excluded. But with hepatitis C, you can get cryoglobulinemia. They can get porphyria cutaneous harda, which is like lesions you get in your hands, like blistering disease. Lichen planus is common, so there's a lot of skin manifestations of hepatitis C, and they often get like vasculitis with albuminal purpura, so you should be careful. Hepatitis C predisposes you to a specific type of glomerulonephritis called membranoproliferative glomerulonephritis, or MPGN. You can get peripheral neuropathy, so you can get a vasculitis and cause peripheral neuropathy. And interesting is insulin resistance. Like people who have Hep C also can have diabetes, and when you treat their Hep C, their insulin resistance gets better. And this association is seen while controlling for people's BMI. Depression and fatigue, like the treatments that were used for hepatitis C used to cause depression and fatigue, and the disease itself can cause depression and fatigue. Non-Hodgkin's lymphoma is also associated with hepatitis C. and cryoglobulinemia. So in the board, like the stem says cryoglobulinemia and hepatitis C is in the answer. Just remember, you should pick hepatitis C, it's usually correct. So there are lots of terminologies used in hepatitis C if you read the literature. So one thing that you need to know is SVR, which is the sustained virologic response, which means you don't have any detectable hepatitis C RNA in your serum, your liver, your blood, your cells. SVR 12 is when you don't have hepatitis C detectable for 12 months, which is 3 months. SVR 24 is for 6 months. SVR 48 is for a year. SVR results in improvement, so the goal of therapy is to get SVR. So SVR results in improvement in fibrosis and even advanced stages of cirrhosis. And if you attain SVR, you can decrease your risk of hepatocellular carcinoma. So this is an interesting study that was published in 2007 from the VA cohort. And what it said is that people who had SVR, you can see that the overall risk of death, hazard of death was lower. Liver-related disease obviously was lower, that makes sense. Non-liver-related death did not change much. Liver failure was lower, hepatocellular carcinoma is lower. Thereby suggesting that everybody with hepatitis C should be treated if there's a way to treat them. The cost of treating hepatitis C is quite a lot, we'll go over that a little bit. But if you can, and you can afford treatment, you should be treated. So what do you do before starting therapy? You basically test for thyroid, because it can be associated with the treatment for hepatitis C used to be interferon, which can be associated with hypothyroidism. You check liver tests, renal tests, vitamin D. You quantitate the amount of hepatitis C in the blood because you need to know that to decide what therapy you go with. You need to know what the genotype is. It's more important in the interferon-based regimens that you know the genomes. But now with directly acting agents, you don't really need to know it that much because there's some drugs which act on all genotypes. There's something called the IL-28B genotype. This was associated with poor response with interferon. If you're not giving interferon for patient, you really don't need to worry about it. The IL-28B genotype is more commonly seen in racial minorities. The bad genotype, that is, everybody has an IL-28 genotype, the worst genotype is seen in racial minorities. You need to check for hepatitis B surface antibody because they're co-transmitted, hepatitis A because they should be immunized against hepatitis A, HIV because it's co-transmitted sometimes. Alpha-fetoprotein to rule out liver cancer and their baseline ultrasound. You need to, most of the problems usually arise with alcohol use and drug use. So most of these patients are actually still abusing alcohol or using drugs, so that's a problem, so you really need to screen them for that. And you need to do a pneumococcal vaccination of those with cirrhosis. So I find this Audit C questionnaire very interesting. Some of you probably use it more often than I use. I use the CAGE, which is not a very great questionnaire for assessing alcohol use. And you know, you can do the math, and I can see a lot of people I know who fall into having an audit score that's pretty high. Like anything like above 2 points is considered, like 4 points is supposed to be bad. A score of 4 is considered positive. So if you drink 2 to 3 times a week, and if you drink 3 or 4 drinks, and if you drink weekly, you're right there. Your audit score is high. So it's pretty high. I mean, if you look at the US population and you use the audit to make somebody decide whether they drink or not, whether they have an issue or not, alcohol-related issue, I think a lot of people will. So I just put it up here because it's something that's interesting to me. So prior to initiating therapy for hepatitis C, you need to find out what other therapies they've received because that decides whether or not you use a particular regimen or not, what type, like did they get an interferon-based regimen, did they get ribavirin, etc., how adherent were they, did they have problems, what were the adverse effects, what were the viral kinetics, so did they suppress, did they have an SVR, and what was the alcohol in treatment. So you need to do an assessment for cirrhosis of the liver, so you need to find out, so most people will get a biopsy in some settings, but there are lots of non-invasive markers which are very good at excluding cirrhosis. So you can use these non-invasive markers to exclude if a patient has cirrhosis. It's not very good in kind of the intermediate stages, but it's good at the extremes. So it's good to say you don't have cirrhosis or you have cirrhosis. One is called the FibroSure. It's most commonly used. It's proprietary, so you can't really go online and just plug in the scores to get it. It's about 5 serum markers that they use, and they come up with a good score. There's something called an EST platelet ratio, which can be used, which is very useful and can be used quite quickly. And there's a FIB-4 index, which also can be calculated. So also, most of these patients will get some sort of a elastography test, so it's like to see how stiff the liver is. It's a very simple test. It's a probe, and you kind of draw a line between the Z40 process, the mid-axillary line, and in the intercostal space, you put the throat, and you get a reading which tells you whether the liver is stiff or not. And if you have all of the other things, you can do an MRI elastography, so you can find out better if not really cirrhosis or fibrosis. So with elastography measures, what you need to know is that this tells you whether the liver is stiff. The liver can be stiff due to inflammation or it can be stiff due to fibrosis. It doesn't tell you that the patient has cirrhosis. So some people in some settings still would like to use a liver biopsy. But my argument is you're going to treat them anyway, so I don't even know why I need to do any of these tests, but that's just my argument. I think we need to do it where resources are not as plentiful as in the military healthcare system. You still need to prioritize your treatment, and the ASLD and the IDSA have guidelines for prioritization of treatment, so people with cirrhosis are prioritized over everybody else. So patients with cirrhosis should have an EGD to rule out portal hypertension, ultrasound to rule out hepatocellular carcinoma. They should have a child-acute Turcotte score calculated. They should have a MEL score calculated. These are calculators that you can get on any online calculators that are available. And they should be considered for referral for transplantation if they have a MEL score that's greater than 10, if they have any history of bleeding varices, ascites, and hepatitis as well. So viral genotype used to be a big issue. In the United States, the most common genotype is genotype 1. There are 6 different genotypes. Genotype 1 is was the most resistant to treatment with interferon, but it's not an issue with the directly active agent, your protease inhibitors. So not much of an issue nowadays. The presence or absence of resistance mutations, so we still need to do a viral genotype to look for this, especially if you're using certain drugs, because certain mutations are associated with less response to certain agents. A viral load, if your viral load is greater than 6 million, your duration of therapy is different than if your viral load is less than 6 million. There's a lot of drug-drug interactions. Every time I see a patient, I actually literally plug in all these drug-drug interactions to figure out what they have. I don't remember it, don't memorize it, but I know that all these drugs have a lot of drug-drug interactions. Some of them are, rifampin, etc., but some of them are, difficult to remember. So you should plug in. If you have a hepatitis B, you should have one of these drug-drug interaction calculator, programs called Lexicon or whatever you use and figure this out. And you need to identify whether they have cirrhosis or not, and if it's decompensated or advanced. So general aspects about treatment that you should know with these drugs is that some drugs have ritonavir. If they're using ritonavir for boosting, there are some drug-drug interactions that you should be aware of. Some combinations of drugs have to be given for ribavirin. Ribavirin is embryotoxic. It cannot be used in pregnancy. It cannot, if a male patient or a female patient who is in a reproductive age group uses it, you have to use 2 forms of protection during both the treatment and for 6 months thereafter. You have to be really rigid about this because it's really, really embryotoxic. And it affects both the male and the female. It's not like just because you're treating the male or female, you don't have to worry about it. Drug-drug interactions are an important concern, again, and there's also interactions with some common things like PPIs that you have to be worried about. So I'm not even going to spell out all these things because they're really difficult to say. I'm just going to give you the generic names because that's what we use, even though we're not supposed to use it in medicine, and that's what we're talking about in school. But the most important ones are Albastavir, Gasopavir, Ledipasvir, Isofosbuvir, and this, which is also known as Spiketerra. And the newest in the market is this one, Velpatasvir and Isofosbuvir. So, just like I said, Albastavir and Gasopavir is also known as Zepatier. And it depends on the duration of treatment, depends on whether you're naive or experienced. From naive as in you've never received any medication before, experienced as in you've received some hepatitis C medication. So if you're naive, you only treat for 12 weeks. If you're experienced and you don't have any resistance mutations, you can treat for 12 weeks. If you're experienced and you have some resistance mutations, you treat for 16 weeks. If you are treatment naive, but you also have or PI experience. If you have this PI experience, you treat for 12 weeks plus ribavirin. So this is the drug that has received a lot of press. This is produced by Gilead Pharmaceutical. If you own Gilead stocks before Harmony came to being, you would be a multi-millionaire right now. Because this is the one that has gotten a lot of press, but it's really, really useful to use. So if you have genotype 1A, you're treatment naive, and your viral load is less than 6 million, provided you don't have any other factors, like you're not African American, you're not older, etc., you can actually treat with Harmony just for 8 weeks. If you're genotype naive, but your viral load is high, you got to treat for 12 weeks. If you have compensated cirrhosis, you can treat for 12 weeks. If your treatment experience without cirrhosis is 12 weeks. If you're treatment experienced with compensated cirrhosis, you can get 24 weeks, and then if you have decompensated cirrhosis, then you have to use regular. That's it's miraculous, there's a lot of bad press about this medication, but all of the hepatitis C medications are miraculous. They've changed the lives of these patients. They've gone from being cirrhotics to people who are completely functioning. In my opinion, the costs are well worth it. So I'm not going to go over this, but this is similar. This is Vicare pack, and this is the dosing for Vicare pack, because I don't think you all need to know this. You should know about the significant interactions of harmony with surfactants and non-sport, anything that's a CYP inhibitor. End-stage renal disease, it can't be given to those whose creatinine is less than 30. You can't co-administer with amiodarone. Vicare, you can't give the child class B and C. It's a moderate CYP3 inducer, and the Zepatier has the drug interaction. So these are the cost considerations. So cost of regimen for 12 weeks. So if you do the Zepatier, it's $54,600, but you have to add a genotype to it. And you can't use it for certain situations, but remember you got to do it for 16 weeks, so there's any pre-existing mutations, so the cost of this is lower. Nadepavir, sofosbuvir is Harmony, it's $94,500. There's all sorts of easiness to the use of this drug because often these patients are HIV co-infected, so it's very easy to give this drug compared to other drugs. Then you have this, the Vicare pack, which is $84,000. So I think the VA uses either this or Harmony. We also use either Zepatier or Harmony. But the newest drug, probably the Hepatitis is probably going to be priced similarly or even lower. So there are a lot of references. Like I said, the UW website has a lot of modules if you're interested. There's the AASLE guidelines, the ISA guidelines. There's lots of web studies for this that are free and easily available for CME. Okay, I'll stop now and ask you any questions if you have anything you have to answer.